Alright, so the subject of this PowerPoint is going to be on oxygenation and the lungs and respiratory system for health assessment. Oh, is this working? Oh, good. Okay, so we know that, get familiar with your anatomy and physiology. I'm only going to briefly touch over it. It's going to be your job to um, get into an anatomy book and read a little bit more on it. But like I said, we're just going to go over the quick basics. We know that there are two parts to the airway, nose and sinuses. Pharynx and larynx, those are in our upper airway. The lower airway has the trachea, the carina, bronchioles and bronchi, alveoli, and accessory muscles. Okay. We can connect breathing with the muscular system, musculoskeletal system, and that is by we know that the contraction and relaxation of chest muscles and the diaphragm cause breathing to occur. We also know that the uh, accessory muscles play a big role in identifying uh, respiratory distress or various other disease processes that can impair breathing. And we also know that breathing does occur not only by muscle involvement, but it also um, plays a role when it comes to um, the exchange of oxygen and CO2 and that regulation. Okay. We know that the lungs are elastic and cone-shaped, and they both consist of an apex and a base. We know that most of breathing occurs in the right lung, okay, about 60 to 65% actually, and I would like you to just think about what that means if that right lung is impaired. We know that we can breathe with one lung impaired. It won't be as effective, however, it can still be done. But what does that mean? What can that tell a person if the right lung is impaired about oxygenation? What can we deduce from that? Well, obviously, if that's where most of our breathing process takes place, it's really going to impact the breathing overall, and will also impact how we treat certain situations. Okay, because the focus will be to get that airway working, to get that lung back in working order. So, again, this isn't just another picture here of your um, of your of the gross anatomy of the lungs. Okay, it shows the alveoli in there. It shows the three lobes in the right lung and the two lobes in the left. Okay, we know that we know that there's both a parietal and visceral pleura. The parietal pleura is the furthest pleura outside of the outside of the lungs, and on top of the lungs you have the visceral pleura. Okay, and between these two pleura, or pleurae if you're using Latin, um, there is there are cells that actually create fluid in there that keep it from rubbing together and causing that pleural friction that you can actually hear. This fluid just allows the it just simply allows the two surfaces to glide across each other smoothly and without any problem. Let's see. As far as oxygenation is concerned, what you need to know is that when air comes in, right, oxygen comes in, CO2 comes out. This is facilitated by red blood cells as they pass through the alveoli. Okay? The flow of blood is actually important to know when it comes to oxygenation and the respiratory system as well, because they both, obviously, all the systems work hand in hand. We know that deoxygenated blood comes in through the right ventricle of the heart, and then it shoots out to the pulmonary artery, okay, where it goes into the lungs, and it goes through the arterioles into the capillary network so that is surrounding the alveoli. Then you have that exchange between the red blood cells and the alveoli. Okay, and then when it comes back, it leaves those capillaries through the venules into the pulmonary vein, into the left atrium of the heart, out the left ventricle, through the aorta, and then out to the rest of the body. Okay. The concept that we also need to learn or know about is hemoglobin saturation. Now there is a video here with this slide. It should work. Otherwise, you can find any video on YouTube about it. But we know that hemoglobin is the site where oxygen binds in the red blood cell. Okay. And delivery of oxygen is actually based on the concepts of partial pressure, which we talked about a little bit earlier. Okay, and we will again visit this when we get to circulation itself. Assessment of the respiratory system. We want to know a lot of things. We want to know how they perceive their health, how many colds they may have had in the past. Have they missed a lot of school or work due to respiratory illness? What are their smoking habits? How much? How many years have they been smoking? We want to know their activity and exercise level. Are they able to complete small tasks without getting exhausted? Are they able to climb a flight of stairs without becoming exhausted? Okay. Are they able to exercise? And for how long and how often? What types of activities? That's also important to know as well. Do they feel like they have the sufficient enough energy to do what they want to do or what they need to have done? We want to know if they've traveled to any other countries or areas of the United States and Canada. There are many different, and we're not going to get too in depth with this, but this is just more for your knowledge. There are areas in our own country where certain fungal infections happen, and knowing if someone comes in with respiratory issues, it's a good idea to ask them that question, and surprise, maybe they do say, oh, I went to Southwest US. You can probably, along with any other symptoms, could probably think, this person might have the fungus of coccidioidomycosis. I can never say that word, but it's written in there, so you can look it up. But that is a fungus, and it is typically found in that area, and it's also the fungus that causes the hantavirus. Okay. Other things that we want to know when we're assessing our patients, and this goes with any area that we're assessing in the body, we want to know their nutritional status, their family history, and any current health problems as well. We're not really going to focus too much on the pack years, so you can kind of just look over that. There is, it's really very simple to do. Okay, you take the number of packs of cigarettes smoked, and then you smoked per day, multiply that by the number of years, and then you will have the number of pack years. Okay. And there is an application question in here for you to look at if you would like to do the math on that. Our assessment, we start in the pharynx and the trachea and the larynx. We inspect the mouth. We can use a tongue depressor to look through the mouth. We want to observe the rise and fall of the soft palate and the uvula. The uvula is that little thing that hangs down in the back of the throat. We want to note symmetry. We want to know color, drainage, edema, any sort of ulcerations. We want to note any inflammation of the tonsils, Okay, we want to know if they even have tonsils or not. Okay, you also want to inspect the neck for symmetry, alignment, masses, swelling, bruising. Though the neck is kind of, you know, another part or part of a different system, it's still something that you want to assess. Okay, because when we're like checking for people who have upper respiratory infections, we're still palpating um, the chains of, or excuse me, the various lymph nodes that are the um, in the neck and various other places as well. They tell us a lot. Okay. The assessment of the pharynx continues with gently palpating the trachea and making sure that it is midline. Remembering that many lung disorders can actually cause the trachea to deviate. You should know a few of them. I will allow you to come up with that on your own. That is Medic Basis 101 there. Usually if the larynx is usually done by a specialist, however, and not by specialist like meaning rank in the army, like a specialist who looks at the larynx and all that stuff, and you can usually note any hoarseness, you know, because that's part of what you're observing, okay? Now this is just a picture of tonsillitis. You do see this. We do see this quite a bit, actually. We do note the exudate, the little white patches that you see on there. We do note the inflammation because that can become an airway obstruction very quickly. We do note that there is, exudate, which would be those white patches on there. We do note the if it's moving from one place to the other. Lots of things that we can note. And that's why it's important for you to assess or to note when something, or to know what normal looks like. If you know what normal looks like, then you will have a very easy time figuring out, that doesn't look right there. That needs to be noted here and discussed with the provider. This is some information for you too about tonsillitis and the invasive group A streptococci, or coccus. Uh, There is acute and chronic tonsillitis. Exudate is indicative of a viral or a bacterial infection. That would be those white patches that you saw on the tongue. When the tonsils are coming together because they're so inflamed, we refer to that as kissing. Strep throat is actually from the Streptococcus group A. They are invasive. If it's left untreated, it can actually cause more problems, like glomerulonephritis, which is affecting the glomerulus in the kidneys, or rheumatic fever, and this can happen within 2 to 3 weeks of infection. Okay. Streptococcal pyogenes is actually what causes scarlet fever, and we do also have a flesh-eating syndrome or necrotizing fasciitis, which begins as impetigo, and this is when the bacteria is introduced through cuts and scrapes. So that last part doesn't really deal with the tonsils and the airway, but it does deal with how invasive Streptococcus is, that particular um, bacteria. Okay. When we're inspecting the lungs and the thorax, first we're always going to inspect. We're going to be looking for the rate, rhythm, and quality of breathing. We need to visually inspect the front and back and make sure that the spine is in alignment. We need to make sure that there's symmetry with breathing. We need to note what type of breathing, whether it may be pursed lip breathing or diaphragmatic breathing. And what that means is pursed lip breathing is like this, right? And you typically see that with, COPD patients. And diaphragmatic breathing is very big, deep breaths right down from the diaphragm. Okay? And we also want to note any use of accessory muscles. We always start from the top of the thorax and we work our way down, going in a side-to-side motion, making comparisons. Okay. We'll get into a lot of that when we do the hands-on about auscultating with the stethoscope and doing the tactile fremitus and all those various things. So again, like I said, we're just looking as an overview, and then we're gonna, when we get into our discussion groups or our at drill portion is when we'll really, hone in on a few things of importance towards our assessments. Again, we're going to be palpating the chest. We talked about that a little bit already. We're going to be looking for crepitus, and we actually see that as air being trapped under the skin, and it's described actually as a crackling sensation on the fingertips. This is also noted as subcutaneous emphysema. Okay. We want to also document any wound sites. We won't be dealing with trachs. Normally we won't be. That's higher level care. And we also want to know, obviously, a pneumothorax if it is suspected. We do deal with chest tubes. So we can actually do those at the aid station with the proper training and the assistance of the provider. We can do percussion as well. That would be the next step in our assessment. So we've done auscultation, we've done palpation, or we've inspected, we've auscultated, we have palpated, and now we can do something called percussion. And that is we can do this ideally to determine the boundaries of organs. We can do that with diaphragmatic excursion. You probably really won't be doing too much of this. However, I will be including that in just as a demonstration thing when we get into the classroom portion of this. The demonstration portion, rather. And really all this is doing is tapping on the chest wall, and you're listening carefully. You can't be in a too loud of area for this, or else you won't hear anything. Okay. There are 5 different tones. Again, something you really don't need to know, but we will be talking about it. And these tones, what they do is they determine the density of underlying structures, fluid, air, or if it's purely solid. Okay. There's again a video here on percussion. Very good video. I encourage you to, if it works for you, to watch it. Percussion sounds. These are the sounds that I was talking about. We want to hear resonance, that is a normal sound. Hyperresonance, that is abnormal. Okay. Flatness is another one. Dullness is what you would hear over solid organs, and tympany is what you would hear over like the abdomen, because and I think you can hear it over the lungs and stuff too. So, but you would hear that it's like a timpani of the actual instrument, right? Air goes to the top, so you would hear that. That would be a normal sound for you to hear. This video is on tactile fremitus, which we'll be going over in the demonstration portion as well. Grab up a friend, try it out and see how it works for you, but really the idea behind tactile fremitus is going to be, do you feel the do you feel symmetry with the vibrations in coming to your hand from the chest, from the voice box to the chest, okay? When we're listening, some good rules of tips here around, we're going back to auscultation here, okay? We want to listen apex to base, and we want to be alternating the sides, okay? So if you are going to do it, it's going to look like this. Now, where would you think you would go after that? If you go from one side then to the other, so 1, 1, right? Would you go over here? No. Go this way, right? 1, 1, 2, 2, right? 3, 3, 4, 4. But when we do it in this pattern, we're not, we're just moving down a little bit over to the next lobes. We're not, it's not going to give us, different findings. It makes it more systematic, and it makes it easier to make good comparisons between the two sides. We want to use the diaphragm of the stethoscope. That's pretty obvious. When we get into like heart sounds, that is when you can actually flip over, and even in the abdomen section, we can flip it over and use the bell, where we're actually listening for more sounds that are only picked up by that particular part of the stethoscope. And those would be like murmurs and bruits and stuff like that. But anyways, back to this here. We're going to be instructing our patient to breathe slowly and deeply in through the nose and out through the mouth. Okay. Breathing through, or excuse me, we don't want them to breathe in through the nose. I jumped ahead of myself. I'm sorry. We don't want them to be breathing in through their nose, because that can create turbulent sounds, which would give you false lung sounds. So it's easier to just have them breathe in through the mouth and out through the mouth, and they do it deeply. Okay. We don't listen over bony structures. We listen to one full breath cycle before we move to the next portion. So that's one full inspiration and one full expiration. Adventitious sounds are pretty much your abnormal sounds. There is a fancy definition. It's an additional breath sound superimposed on normal sounds, and they indicate pathological changes in the lung. That's great. Woohoo. Pretty much it's an abnormal sound. So that's why you want to be able to recognize and know what normal breath sounds are like. When we get into the demonstration portion, each and every single one of you will be going at least once to the other person, or to another person, throughout that time. So it'll be done quickly, but it will be, each of you will at least listen to the other person, to another person, multiple times, and other people throughout our practice time. Okay, so you can get good at hearing it and recognizing what normal is. With any luck, since we're getting into the cold season, we might end up hearing a couple others abnormal sounds. So this is actually a video here on how to listen to the lungs. Again, remember, we're going to be doing that systematic, 1, 1, 2, 2, 3, 3, 4, 4. Listening to all the fields of the lungs, and making sure we get a good reading on those sounds. Pulse oximetry. This is very simple. We know about this, that it is the measurement of the hemoglobin saturation. Usually hemoglobin is almost 100% saturated with oxygen. Our ideal normal value is anywhere from 95 to 100. Normal values are going to be a little lower in older adults and people with darker skin. The oximeter can detect desaturation before any manifestations happen, so that's why it's important to have that oximeter on a patient that is unstable. Also, it's important for someone that maybe who you suspect will probably end up having or had like an asthma attack or something, and you want to keep that on there so you can keep watch and make sure that your treatments are working. We can get false low readings, and this is something that you do need to know. If we have, sometimes the females have nail polish on, that can give us a false reading. Edema in the fingers can give us a false reading. Decreased hemoglobin, which can easily happen from blood loss, can give us a false reading. Ambient light can give us false readings. The decreased peripheral blood flow, which we talked about just a little bit ago, that can be from a lot of different things though too. Patient movement, this is why it's important to have them lay still. Hypothermia, that's a big one, which we can end up dealing with too. Results lower than 91 are bad, we know that, but if the patient drops below 86%, it's considered an emergency and requires intervention. I'm not concerned that you know the lab values for red blood cells. Um, I am concerned. I do expect you to know the hemoglobin lab values. Okay. Keep in mind, hemoglobin is going to be abbreviated HGB, capital HGB, or even capitalized H, capital G, capital B. Just depends on what machine you're using. We do have a machine to do that actually in our clinic room at the Armory. Keep in mind it is not going to be Hg. There is a difference. One is hemoglobin and the other is mercury. Okay. The values that you should know, they're roughly going to be for a female is 12 to 16 grams per deciliter, and for a male it's going to be 14 to 18. Okay, those are the two values that you should know. They will show up on papers, okay, and I will ask you about them. You also should know what normal pH is, just for your own knowledge, okay, because later we'll end up starting to talk about acidosis and alkalosis. Uh, the normal pH is going to be 7.35 to 7.45. So really, that's only a tenth of a difference. And our body compensates lovely for that with the lungs and the kidneys. Very happily it does that. And we'll get more into that as we go further. But please know those lab values for hemoglobin and normal pH.